Hello and welcome to this guest webinar being organized by NephroPlus in collaboration with the Kidney Warriors Foundation, India's largest kidney patient support group. At NephroPlus, we would like to thank Vasundhara Raghavan and the entire Kidney Warriors Foundation team for partnering with us in this series of webinars that are meant for dialysis patients. We hope to organize one such webinar every month on topics of interest to dialysis patients. And I am really delighted that the Kidney Warriors Foundation is partnering with us in this very good initiative that will hopefully help a lot of dialysis patients get their doubts clarified, get a lot of information and knowledge about their dialysis treatments. So today, the topic that we have chosen is your lifeline on dialysis, understanding, caring for, and protecting your access. We have a very eminent speaker who will go to join us shortly. He's just got called into the OPD for an emergency, but hopefully he should join us shortly. In the meantime, I'd like to just talk a little bit about this topic from a patient's perspective. I'm a dialysis patient myself. My name is Kamal Disha. I'm the co-founder of NephroPlus, and I've been on dialysis for the last 28 years. I currently have an AV fistula, and I think most people on dialysis would have at least heard that term, AV fistula. But let me just talk a little bit about the different types of dialysis access and what the advantages and disadvantages are of each one of them. So, and hopefully we will have Dr. Prasoon Roy, our guest speaker, join us very soon. And we will delve into the clinical topic, the clinical aspects of a fistula, of different types of accesses and so on, once Dr. joins. But until then, I will just talk about it from a patient's perspective in terms of what exactly an access means. So a dialysis access primarily means that it is a way for the dialysis machine, and I'm talking currently only keeping hemodialysis in mind. A dialysis access in hemodialysis basically means a way to access the blood in our veins, in our body, for it to be drawn out, run through the dialysis machine, which has the dialyzer or the artificial kidney, and the blood will go through that and then be pumped back through the same access into another part of the vein. So broadly, an access for dialysis simply means a way for the dialysis machine to get access to the blood in our veins. Now, there are multiple types of accesses. Broadly, if you look at it, there are permanent accesses and there are temporary accesses. Now, temporary accesses are things that can be used only for a short duration of time. It cannot be used for very long. It is mainly meant for a quick and easy way to start dialysis. Unfortunately, in many countries, and especially in India, a lot of patients don't get a lot of time to plan their dialysis journey. A lot of patients get diagnosed right at the very end of the end stage kidney disease, where they need emergency dialysis. So they would typically end up having a lot of symptoms of kidney failure, like nausea, vomiting, breathlessness, and other such symptoms. And they suddenly realize that they need help. They come to a nephrologist or a general physician who would eventually refer them to a nephrologist. And then the nephrologist would run some tests and then realize that this patient suddenly needs dialysis. At that point, a temporary access is usually used to get access to the blood for the doctor and the medical team to be able to perform dialysis and help the patient to feel better. Now, a lot of patients who get temporary accesses get something called a jugular catheter or a permanent catheter, and in medical terms, it can be called a non-tunneled catheter or a tunneled catheter. Now, while a tunneled catheter is also called a permacath, which kind of hints that it may be permanent, but we should not mistake a permacath for a permanent access. Permanent accesses are different, and I'll talk about that in a minute. Now, these temporary accesses typically have a kind of an incision made somewhere in the chest, in the neck, or somewhere in the body where a tube is inserted from outside, and that provides the access to the blood. Now, the disadvantage of this kind of an access, which is a non-tunnel catheter or a tunnel catheter, are that there is a site in the body that is open, in terms of it is not evidently open, but it's not the skin does not cover that access. There is a way for bacteria to grow, and that can be very dangerous for patients. That is why most dialysis patients who get a temporary access, a plan is made for them to quickly move as soon as possible to a permanent access where the chances of infection are much, much lower. So tunnel catheter, non-tunnel catheter, among these two, if you look at it, a tunnel catheter has a lower chance of infection and complications compared to a non-tunnel catheter. Now, I don't want to get into too many details on that. We'll leave that for our guest speaker to talk about. But from a patient's perspective, there will be some kind of an access open here, some kind of a opening here, which is prone to infection. So then there are restrictions on us, while taking a shower, we cannot go for a swim, for example. All these things increase the risk because we should not get that area to be wet. If you get it wet, then there's a high chance of infections to happen. Now coming to permanent accesses. Permanent accesses are of two types. One is an arteriovenous fistula or an AV fistula, AVF, and the other type is an arteriovenous graft or an AV graft or an AVG. Now, in this also, an AVF or an AV fistula is supposed to be much better. Now, what's the difference between the two? Both have the advantage that there is no external opening, there is no risk of high risk of bacterial infection, because whatever is done below the skin. There is no access, there is no opening in the skin. It is all done below the skin. But there is a small difference among an AV fistula and an AV graft. An AV fistula basically has the artery and the vein inside the body or below the skin connected, and an AV graft has that connection, but it is not a natural connection. It is connected by a synthetic material. So among these two also, the AV fistula is much more natural. It is less prone to infections and complications compared to an AV graft as well. So now, why do people say that an AV fistula is the gold standard when it comes to dialysis access? So when it comes to dialysis access, an AV fistula is considered the best form of dialysis access. Multiple reasons. One is it is completely within the body, it is below the skin, and there is no unnatural material involved. It is just a joint. It's called an anastomosis in medical jargon, where the artery and the vein are connected together. Now, why the question might be is why can't we access the vein directly? Why do we need this fistula? Why do the artery and the vein need to be connected together? Now, an artery typically has much higher blood flows than a vein. Okay. Now, when we are doing dialysis, we need to squeeze a complete week's worth of cleaning of the blood, which healthy kidneys would have otherwise done in 12 hours of dialysis treatments, assuming the patient is doing 3 times a week, 4 hours every time. So in those 12 hours, we need to get the complete cleaning of the blood done, or at least as close to natural kidneys as possible. Now, even if you do thrice a week, 4 hours, those 12 hours are not going to reach even 10%, they say, of healthy kidney function. But the goal is to get as good cleaning as possible in those 12 hours in the week, to get good clearance and to have a good quality of life. Now, if we do not create this joint between the artery and the vein and improve the pressure of the blood in the vein, we are going to be accessing the blood only in the vein. The arteries typically are very deep, so we cannot access the arteries. What is accessed is only the vein using the needles that all of you are familiar with. So the vein needs to have high blood flows for the dialysis to be efficient, because in those 4 hours, we need to get a lot of blood out through the vein, through the arterial needle, through the artificial kidney, and back to the body. So unless we connect the artery and the vein, we do not get enough pressure in the vein to be able to achieve good clearances during the dialysis session. That is why a fistula is created. So we join the artery and the vein becomes arterialized, where the blood flow in the vein also becomes higher. The pressure becomes higher, which leads to better flows during the dialysis session, and it leads to better clearances during the dialysis session. So that is why you need an arteriovenous fistula. I'll pause here for a couple of minutes and see if anybody has any questions on what we have discussed so far. Hopefully, our guest speaker will also join in the meantime. But anybody has any questions in the meantime, please let me know, and then we can have a discussion. I don't claim to be an expert, but I've been on dialysis for a while, so I know some very basic details of dialysis accesses. So if there is something that I can answer, I would love to be able to do that right now. So Dr. Roy will be joining us very soon. But in the meantime, if anybody has any questions, please feel free to ask them now. Yeah, I think Amar has a question. Please go ahead and ask. Amar, you've raised your hand. Please feel free, go ahead and ask. You can type your question in the chat box or okay, there's a question here in the question section. Can we do muscle exercises with a hand fistula? So it depends on how new the fistula is. If your fistula has been created very recently, like less than the 4 weeks or the time it takes to mature, when you're able to do dialysis freely without any problem, at that point you should not do weight exercises with your hand. You should do the exercise of the ball, the squeezy ball that is given to you at the end of your surgery. You should do those exercises, but not strength training exercises with weights, for example. Those should not be done until your fistula has matured and you are getting good flow or good dialysis with that fistula. Let's say a few months have passed and your fistula is totally fine. The technicians are able to get good flows from it and there is no problem. At that point, you can slowly start doing strength training exercises with your fistula. You can start very, very slowly, very gentle exercises, and then slowly increase it. Always remember to talk to your doctor and ask them before you do any specific exercise or any change in your schedule. So broadly, exercises related to the hands, strength training exercises are allowed once your fistula is mature, not before that, and that to start slowly. How to control phosphorus? That's not related to this topic, but very quickly I'll answer since we have some time and Dr. Roy, we're waiting for him to join. But I think phosphorus can be controlled primarily in 2 ways. One is by diet and the other is by taking phosphate binders. Diet in terms of red meat especially has high phosphorus. Most non-vegetarian food has high phosphorus. Milk products, high phosphorus. So reduce consumption of high phosphate foods. And second is to take your phosphate binders. I'm sure if your phosphorus is high, your doctor would have advised you to take phosphate binders. So please take your binders in time. So that is the answer for that. You've been on dialysis for 2 years, Shahina Pasha. Yeah, thank you. And I think I've answered your question. Use of belts after closing, while it is used widely, and there are no major issues using that, but make sure it is not too tight for too long. Once your uh, fistula has once the sites have clotted, make them a little loose and then remove the belts. Don't keep it for too tight for too long. Ideally, of course, if there is a way to avoid belts, try to avoid belts, but for short periods, belts should be okay. It might harm AV fistulas. Yes, that is true. But the point is, if there is no other way for short periods, it may be okay to use. But again, this is something you should talk to your doctor and your care team at your dialysis center. There is a question here on the chat, on Facebook, how to take care of your AVF fistula, as I'm working in corporate, not able to take care of it on regular basis. So I think the most important thing is to keep it clean, to not let it become dirty, to make sure that you wash it when you're having a bath nicely with soap and water without scrubbing too hard. Very gently wash it and then dab it with gauze pieces and dry it quickly, and then go about your normal thing. Second thing is, don't carry bags, and don't press that area of the fistula with, let's say, a bag or a lady's bag and those kind of things. Try not to put the strap of the bag on that fistula. Try to keep it free, clean, neat, and don't put too much pressure on it otherwise. Okay, the next question is, my father survived with AVF for 14 years. The expert surgeon and good dialysis technician need to be appreciated. I have seen some cases where fistula often fails anytime. Very, very true, Durga Sarathi ji. Very, very true. I think the surgeon plays a big role in creating a good fistula, and technicians also play a very, very important role in maintaining a fistula for a long time. Unfortunately, sometimes, due to various reasons, the needle can go across and it can cause various complications with the fistula. So technicians need to be very careful. Wherever the needle is used on my fistula, kind of bump is there. There are 4 such bumps on my arm in 11 years. Is it normal? It is there for many patients. These are called aneurysms. So especially when you cannulate at the same place, there is a likelihood of a small aneurysm forming there. So try to tell your technician to keep cannulating in different places after every session, and not cannulate in the same place unless you're using the buttonhole technique. Buttonhole technique, unfortunately, is not very commonly used in India. But for sharp needles, always use a different site each time. Ruchi, I hope I've answered your question. How many years we can continue for dialysis? I think there is no limit to the number of years anybody can be on dialysis. I myself have been on dialysis for 28 years now. And there are many people in India also and outside India also who have been on dialysis for 30, 40 years. So there is no theoretical limit as to how long somebody can be on dialysis. It all depends on how well you maintain your health to get. And what do I mean by that? To basically get dialysis as prescribed by your doctor. Supposing the doctor says 3 times a week, 4 hours each time, please make sure you do that. Do not cut corners if possible. I understand there are some financial issues that people have, but as long as you are able to manage, don't try to reduce the time of your dialysis. Don't try to reduce the number of sessions per week. Follow the doctor's advice. They're saying things for a reason. So if we follow the doctor's advice, eat a good diet, eat a high protein diet, do some exercise, then all of us can lead completely normal lives and live for many years on dialysis. I'm delighted to let you all know that Dr. Prasoon Roy has just joined us. And as he's connecting to audio, I'll quickly just take one last question. How long dialysis can be done through permacath? I think I'll leave that question to Dr. Prasoon Roy to answer once he gets connected to the audio. Welcome, Dr. Roy.
Hi.
I'm delighted to welcome Dr. Roy. Amia, if you can just look at Dr. Roy's video, I think there's a little bit of blurring there. Can you just check what the problem is?
Yes, sir, checking.
Yeah, great. So I welcome Dr. Prasoon Roy, to this webinar. Dr. Prasoon Roy has completed his MBBS and MD from National Medical College, Kolkata, followed by a DM in nephrology from IPG-MER in 2019. Dr. Prasoon Roy is also the medical director of NephroPlus's Arambagh Center in West Bengal. He's a life member of the Indian Society of Nephrology and the Indian Society of Organ Transplantation. In addition to his clinical work, Dr. Roy is also actively involved in academic research. His publications focus on practical and impactful areas, such as outcomes of tunneled venous catheters for maintenance hemodialysis, methods to reduce bloodstream infections in dialysis patients, and the management of dyslipidemia in patients with rheumatoid arthritis. With a strong academic background and a passion for clinical excellence, Dr. Roy plays an important role in advancing kidney care. We are delighted to have you with us today, sir. Thank you so much for taking out time and joining this webinar, which NephroPlus is organizing. NephroPlus is Asia's largest dialysis service provider. NephroPlus is organizing this webinar for dialysis patients in collaboration with the Kidney Warriors Foundation, India's largest kidney patient support group. So welcome, Dr. Prasoon Roy. Thank you so much for joining. And I'd like to, since you were a little late, I just gave a little bit of background from a patient's perspective because we had people already joining the webinar. But let me just begin this session with you by saying that, how can patients take care of their access at home on a daily basis? And if you could talk a little bit about, the catheters and AVF, AVGs, that would be very helpful, Dr. Roy.
Usually in our countries, we prefer the AV fistulas as the primary access. However, if actually in some cases there is acute initiation of dialysis, when there is unplanned dialysis initiation, in that case, we prefer the tunnel cuff catheter over the conventional catheters. AV graft is a bit less used in our parts. However, there are some patients actually who are on AV graft. We usually use the AV fistulas and then the tunnel cuff catheter. These are the common practice.
Got it. And like, what can patients do to take care? There was a question, in fact, before you joined, that one patient asked, is that what can I do to take care of my AV fistula? Any tips on how what can patients do to, make sure that AV fistulas are healthy and last for long?
Uh, the important thing is there should be no IV prick in that AV fistula. So we may use it for the intramuscular injections, but no intravascular injections in that term. We should avoid the blood pressure measurements in that term. We should avoid the pulling up the heavy weight in the term, and we should not put any pressure on the term. These are the primary care for the AV fistulas. And for the other cares, we should have a gentle rub over the AV fistula when bathing. So our fistula remains clean, but it should not be undue pressure should not be over it. And from our technician part, if the buttonhole technique can be used, it is better. However, sometimes it is not possible to have buttonhole unit because of some various reasons. So if buttonhole process is possible, then
What about catheters, doctor? Like, some people have tunnel catheters, non-tunnel catheters. What can patients who have catheters do to ensure their catheters are safe and they don't get any infections and other complications?
the catheter side should be kept clean. However, we shouldn't soak it directly. So the showering is preferably to be avoided, and it is better to cover the part and having cleaning the part actually. So
Got it.
this is number one part. Number two part is from our technicians. who should have the regular dressings with all aseptic measures. It should be kept, and the skin around the exit port, this is very important site for the introduction of the infections. So cleaning of that part is very much important.
Got it. Got it. And but there's one question that one patient has asked, doctor, is that how long can dialysis be done through a permacath, which is a tunnel catheter? How long typically can it be used? For how many months?
At least it can be used for months, many a months. If otherwise there is no such complications and the perm cath is placed or kept in hygienic condition, we can have it for many years.
Got
But
it.
usually 1.5 to 2 years is usual.
Okay, okay, got it. And there's one question about the thickening of the blood vessel or the around the area of the fistula where the cannulation happens. That area becomes thick. So some patients get worried that why is this area becoming so large? Why is the vein expanding? Why is the vein becoming so ugly? So is this a normal thing? Should we be worried, or is this something that is seen is common?
No, the swelling of the overall vein is common. Swelling of the overall vein is common. The fistula is having a high flow, high blood flow. So there is an arterialization of the veins. So swelling of the blood veins is common. However, the thickening is not so usual. And but however, when the patients are in long duration with a single fistula, and there are multiple pricks 2 to 3 times in a single week, so the arterial wall gets thickened. So this is a possibility. We should have a check, and the adequacy of blood flow is should be ensured. Actually,
Got it.
we can use a thrombophob gels and ice, so that the it's remain
Okay.
patent.
श्योर एंड एक और क्वेश्चन आया है डॉक्टर साहब हमारे दर्शकों से कि जो नीडल्स लगती हैं वो आर्टरी और वीनस जो नीडल्स है वो दोनों सेम डायरेक्शन में होनी चाहिए या ऑपोजिट डायरेक्शन में होनी चाहिए उस पे कुछ आप बोल सकते हैं
Actually, if it is in same direction, then there is a chance of recirculation. So to but if we keep it in the sufficient distance, there is less issue. Less issue. The
गॉट इट
relation in that cases doesn't become a great issue.
Got it. Some of our viewers have requested to mix up a little bit of Hindi, Dr. Saab. If you are
Okay, okay.
comfortable, we can just mix up English and Hindi. तो next
अच्छा.
question मेरा है डॉक्टर साहब आपसे कि जो नीडल्स कैनुलेशन के लिए हम डालते हैं एवी फिस्टुला में तो वो हर सेशन सेम स्पॉट पे कर सकते हैं बटन होल नहीं यूज कर रहे हैं लेकिन शार्प नीडल्स यूज कर रहे हैं शार्प नीडल्स यूज करते वक्त सेम स्पॉट पे कैनुलेशन इज इट ओके और you would advise to do
नहीं,
different
अगर
spots.
बटन हम लोग यूज करेंगे तो ये सेम स्पॉट ठीक है, लेकिन अगर हम लोग बटन यूज नहीं कर रहे, शार्प नीडल्स यूज कर रहे, तो साइड चेंज करना अच्छा है.
Okay, okay, ठीक है. One question I had, Dr. Saab, is that what kind of monitoring should patients do, at home on their access on a daily basis? And I'd like you to request you to answer for both AV fistula, AV graft, and for catheters. What kind of monitoring should be done by the patient at home? Patient को क्या ध्यान में रखना चाहिए? क्या रोज उनको चेक करना चाहिए? ऐसे कुछ आप 2-3 अगर हमको एडवाइस दे सकें कि कैथेटर्स में रोज क्या चेक करना चाहिए और फिस्टुला या एवी ग्राफ्ट हो तो व्हाट शुड बी चेक ऑन अ डेली बेसिस
कैथेटर में जो चेक करना चाहिए कि कोई पास पॉइंट्स तो नहीं हो रहा है, ये साइड पूरा क्लीन है कि नहीं है, ये सब हम लोगों को देखना है. ठीक है, क्योंकि अगर ये साइड अगर सोक्ड रहेगा तो उसमें चांस ऑफ इन्फेक्शन ज्यादा होगा, तो ये सोक्ड नहीं होना चाहिए, क्लीन होना चाहिए. ये तो कैथेटर साइड के लिए इम्पोर्टेंट है. और एनी अनड्यू कैथेटर पुलिंग कुछ नहीं हो रहा है कि नहीं है, वो थोड़ा देखना है. ठीक है, कि कोई नींद के टाइम स्लीप ड्यूरिंग द टाइम ऑफ स्लीपिंग कोई कूलिंग ऐसा तो नहीं हो रहा है, ये देखना है. ये तो कैथेटर के लिए इम्पोर्टेंट है. और फिस्टुला के लिए तो फ्लो जो होता है वो तो सबको पता ही चलता है कि फिस्टुला में फ्लो ठीक ठाक है, ये देखना है. कोई ब्लीडिंग स्पॉट्स कुछ है कि कोई इन्फेक्शन कुछ स्पॉट्स ऐसा कुछ है हो रहा है कि नहीं, ये थोड़ा देखना है.
So I think Dr. Saab is saying, viewers, that for fistula, I think one important thing the doctor mentioned is whether it is working or not. So I think that sensation of zoom, zoom, zoom,
Yeah.
that's something that you should check. And अगर वो stop हो जाए तो तुरंत डॉक्टर से कंसल्ट करना चाहिए.
स्टॉप हो जाए कि ये स्लो भी हो जाए तो,
स्लो भी हो जाए तो
स्लो भी
करेक्ट
हो जाए तो.
करेक्ट
और
करेक्ट.
ब्लड प्रेशर थोड़ा मेंटेन करना है, पर्टिकुलरली फॉर फिस्टुलस, बिकॉज पर्टिकुलर अगर ब्लड प्रेशर बहुत लो हो गया तो फिस्टुला में असर आ सकता है.
ओके ओके. एक क्वेश्चन है डॉक्टर साहब कि somebody saying that why catheter is called temporary vascular access. You had mentioned that a tunnel catheter can be used for, there is no limit, it can be used for as long as possible. So the question that one of our viewers, Rashid, has is that why is it called temporary vascular access if it can be used for unlimited amount of time?
Yes, it can be used for unlimited times, but theoretically, a foreign body is introduced in the body. So whenever there is a foreign body, there is a increased chance of infection. So chance of infection is always more in the AV, in the tunnel cuff catheter than the AV fistula. AV fistula is the best option whenever possible. And we have seen patients for 7 years, 10 years having a single functioning AV fistula, and but 7 to 10 years having a single tunnel catheter is less likely.
Got it, got it. And in terms of this catheters, doctor, like how long can the non-tunneled catheter be can be used for non-tunneled catheter?
A non-tunnel catheter is not preferred option. However, in some cases of some emergency situations, we have to put it, and we should keep it at least maximum 2 to 3 weeks
Okay,
for femoral, and for the jugular lines, uh, max at max 4 weeks at max.
got it, got it. Okay. The next question I had, doctor, is that are there any new treatments or technologies that you are aware of, or you think that are coming up or in the pipeline to improve, the whole access? Is it to make it longer, to make it less painful, or whatever, to just improve access? Is there some new technology that we can expect in the coming years?
A buttonhole technique is a technique which can be used, and we should use it more for the for less pain and for the maintenance of the fistula for more. And there are some ointments which can be used for the making it the less painful.
Can you give us some example of which ointment we can use, doctor, if possible?
Actually, there is some lignocaine types ointments which can be used around 30 minutes earlier than initiation of the dialysis for making the overall procedure less painful.
Got it. Got it. Why is a fistula considered the gold standard, doctor? Like, what is so special about a fistula that, all of us should aim to get a fistula as soon as possible? What is the reason behind it?
As I have already told that there is no foreign body introduced in the AV fistula. AV graft is a foreign body, tunnel catheter is foreign body, and whenever there is a foreign body, there is more chance of infections. In the AV fistula, the person's own artery and veins are just tied, anastomosed, and they are in close proximity. The overall thing is a physiological, a bit physiological.
Got it. Got it. There is a question that has been asked. Is there any test or method to check fistula health or condition other than checking the thrill? Like, other than checking the
Yeah,
thrill, is
other
there
than
anything?
checking the thrill, the Doppler, AV fistula Doppler, along with the Doppler of the surrounding veins and the central veins. Because many a times, especially when there is the brachiocephalic fistula in the arm, so there is chance of the central venous obstruction. So if there is central venous obstruction, whenever be the AV fistula flow, the overall flow is not good. So along with the AV fistula Doppler, we should have the draining vessels Doppler and central venous Doppler.
Got it. Got it. And many people have their fistulas on the wrist, doctor, like right here, whereas
Yeah.
some people have it, upper arm. Uh, what is the difference and which is better? Like supposing, somebody, a new dialysis patient is asked, you want a fistula on the wrist or in the upper arm, like what would you recommend? Is one better than the other, or are both same? What should a patient pick?
No, if the venous condition and arterial wall condition is fine, then we should prefer the radiocephalic fistula, which is done on the wrist and of the non-dominant hand. That is for left hand as a for a right-hand person,
Got it.
because the working hand should, if possible, should be spared because the weightlifting is a issue. The best is the non-dominant hand radiocephalic fistula at wrist.
गॉट इट गॉट इट और ऐसे कितने साइट्स हैं डॉक्टर साहब बॉडी में अभी समझिए कि कोई डायलिसिस पे लंबे अरसे से है 10 10 12 साल 15 साल उससे भी ज्यादा तो कभी कभी उनके जब फिस्टुला फेल हो जाती है तो दूसरा साइट डॉक्टर लेके फिस्टुला बनाते हैं तो ऐसे कितने फिस्टुला बॉडी में बना सकते हैं कितने साइट्स है बॉडी के जहां फिस्टुला बना सकते हैं
यूजुअली हम लोग जो करते हैं तो वो हैंड्स में होता है और आर्म्स में होता है, द रेडियोकेफेलिक वन एंड द वेसियोकेफेलिक वन. However, in this part actually, am I visible?
नो इट्स गेटिंग ब्लर्ड एक्चुअली या
Yeah. uh, in a part over the wrist, the anatomical snap box कहते हैं वो प्लेस को, वहां पर भी फिस्टुला भी हो रहा है थोड़ा. कुछ कुछ साइट्स में फिमोरल एपिफिस्टुला भी कोशिश हो रहा है. फिमोरल ग्राफ्ट होता है, फिमोरल फिस्टुला भी होता है. But these are not usual sites. Usual sites are the both hands, the wrist and the arm.
मतलब कॉमनली 4 होते हैं
Commonly
लेकिन
चार
कभी
होते हैं.
कभी अगर उससे ज्यादा पड़े तो हताश होने की जरूरत नहीं है जो कभी कभी जरूरत पड़ी तो पैर में भी कर सकते हैं और 2 3 जगह है जहाँ
हो
थियोरेटिकली
सकता
हो
है,
सकता है वो
हो सकता है.
डॉक्टर से बात करके डिस्कस कर सकते हैं तो अभी क्वेश्चंस के लिए ओपन करते हैं डॉक्टर साहब इफ एनीबडी हैज एनी क्वेश्चंस दोज हु आर ऑन द जूम लिंक यू कैन प्लीज टाइप इट ऑन द क्वेश्चन बॉक्स और द चैट and those who are on Facebook can please type their questions on the Facebook comments. Our team will paste the questions here so that Dr. Roy can answer those questions. So please keep those questions coming. Access is such an important aspect of dialysis. Access जो है फिस्टुला कैथेटर्स वगैरह बहुत ही डायलिसिस में इंपॉर्टेंट है तो हाँ एक क्वेश्चन आया है currently facing hypertension in many patients with fluid overload 4 to 5 liters in each session. Please suggest something special for that. Hypertension with fluid overload. This is not related to access, Doctor, but maybe we can take it up if you permit. Ke
Yeah.
patient is facing hypertension with fluid overload. Anything special can be recommended for that clinically.
Actually, the dialysis patients are the fluid sensitive and salt sensitive. So the hypertension is maximum due to the fluid overload actually. So we should increase the duration and frequency of the dialysis so that there is efficient clearing of the fluids, number one. Number two, at least at the end of the hours, we should decrease the sodium load, because whenever there is a sodium accumulation in the body due to prescribing the high sodium in the machine, so it draws the water actually. It increases thirst, so patient drinks water and it gets retained in the body. So two parts. We should increase the ultrafiltrate, we should decrease the sodium at least at the terminal hours.
Got it. Got it. और एक क्वेश्चन आया डॉक्टर साहब कि डायलिसिस पेशेंट्स जिम को जा सकते हैं क्या और आपके ज्वाइन होने के पहले और एक क्वेश्चन था इसी लाइन पर कि कैन डायलिसिस पेशेंट्स डू स्ट्रेंथ ट्रेनिंग मतलब स्ट्रेंथ एक्सरसाइजेस विद देयर हैंड विद देयर आर्म if you could just answer that that's a very important question that many people have
Actually, currently there is a focus on exercising in the dialysis patients. There are some trials actually when the patient was having some sort of exercise during dialysis also, like static cycling, etc. But one thing to be ensured that the strength exercise should be of that degree which doesn't harm the AV fistula.
Got it. Got it. So I hope, Sam G, your question has been answered. Dialysis patients can do strength training in the gym, but they just need to do it slowly, talk to their doctor, and not do anything that can cause harm to the patients. How to determine dry weight? Again, a question that is not relevant to the current topic, but I think we do this so less. We do it only once a month. So hopefully, if you don't mind, you can answer that question, doctor. How to determine dry weight?
Dry weight should be measured clinically and the BCM analysis. BCM analysis is an important tool for the dry weight assessment, and the patient clinical condition is important. Whether he or she is having the peripheral swelling, peripheral edema, whether she is having the fluid overload, chest crackles. If these are present, then the patient is having definitely overload, and we should try to achieve a condition when the BP is just good and patient is having not cramps. There are other some methods like crit lines also, but these are not usually used. These are for the experimental basis maximally.
Got it. Got it. There's one question कि patients जो stage 4 और stage 5 पे है और dialysis अभी start नहीं हुआ है, what suggestions would you like to give in terms of vascular access for these patients?
If the patient is having the stage 4 CKD and a bit advanced like GFR is less than 20, we should discuss about the options. And actually in this new guidelines, the kidney failure risk इक्वेशन बोल के एक चीज होता है कि वहां पर अगर देखा जाए कि नेक्स्ट 2 years में उसका रिस्क ऑफ गोइंग टू डायलिसिस अराउंड 40% और मोर, सो इन दैट केस वी शुड मेक द एवी विशुला डन so that we can plan it beforehand then the dialysis initiation, and whenever dialysis is indicated we can use it.
Yeah. Any exercise for maintaining AV fistula asked by Geeta? Any exercise you would recommend?
The
maintain?
isometric hand grip exercise is the typical one, the ball लेके pump करना है, तो हम लोग वही सजेस्ट करते हैं, isometric hand grip exercise.
ओके ओके। और एक क्वेश्चन आया है, मैं प्रीति सागर हूँ। अगस्त 2024 में से सप्ताह में 2 बार बुधवार और शनिवार को भागलपुर नेफ्रोप्लस में डायलिसिस कराती हूँ। मेरा वेट 44.5 है। पीच बीपी इन दिनों ठीक ठाक रहता है। 1 मई को मेरा क्रिएटिनिन लेवल डायलिसिस के बाद 3.7, यूरिया 20, हीमोग्लोबिन 7, सीआरपी बुखार आ रहा था। डॉक्टर ने मोनोसेफ अक्सर क्यों मेरा सीआरपी बढ़ जाता है? ये दिस इज वेरी वेरी डिफिकल्ट टू आंसर आई थिंक ऑन अ
Yeah,
this kind
without
of
seeing the
session is a
patient.
very medical question. So please, Preeti Sagar ji, you should talk to your doctor about it. This is not this is very clinical and very individual specific. Are there any other permanent accesses like fistula? Apart from fistula, is there something similar to a fistula, Roxab?
AV graft.
AV graft, right? We talked about it. Is there any way to prevent clotting at inside or site of anastomosis, because we follow the heparin doses as per the weight?
So if there is the indication and there some patients have the increasing coagulability, the average lifetime of the dialyzer is less, we have to, if we have to change it earlier, we should increase the heparin dose. We
Got
should
it.
increase the heparin dose.
Got it. So if there are,
And in some cases, the antiplatelets like aspirins or clopidogrels are used.
got it. Got it. I hope that answers Divyesh ji's question. Any other questions anybody has on this very important topic at this webinar for dialysis patients being organized by NephroPlus in collaboration with the Kidney Warriors Foundation? What are the better alternatives for belt for dressing post dialysis, doctors? I think बहुत लोग ये फिस्टुला के अपना डायलिसिस के बाद जो कुछ टॉर्निकेट्स होते हैं, बेल्ट्स होते हैं, वो यूज करते हैं. Is that safe to use, doctor? There was a question that came even before you had joined. In your opinion,
If
is that
there
okay
is
to use?
increased bleeding tendency, then we should use it. If there
Right.
is no increased bleeding risk, so we may avoid it.
Got it. Got it.
Because if we give the undue pressure, it may hamper the health of the fistula or the veins.
What are the alternatives for belts is a question that they're asking. Like अगर वो नहीं use करते हैं तो और क्या use कर सकते हैं?
They just sometimes they just pushing the palm pressure for few minutes is sufficient.
Got it. Got it. I hope, Ruchi ji, that answers your question. Question again, not related to the topic. Which medicine is good to increase hemoglobin?
There is no such thing that this thing is good for hemoglobin increase. The fall of hemoglobin is due to many factors, and we have to address the factors actually. We usually patients having the low iron, so iron injections, erythropoietins, some persons desidustat, these are used. But there is no such thing this is good or this is bad. The treatment should be according to the cause of anemia.
Okay. How has your experience been with the HIF, PHI, doctor, the desidustat and all? Have you seen good results with it or still
Yeah,
too early
result
to?
is good. Result is good. At least in 60 to 70% patients, result is good.
Nice,
In
nice.
dialysis patient, there may be increased requirement of doses like 150, 100 to 150. And in
Got it.
non-dialysis populations, okay, 50 to 100 is okay.
Nice,
But
nice.
there should be the specific indication of the use of the HIPFA unit.
Of course, of course. Please suggest something for heel and feet pain on dialysis from 8 years. Heel and feet pain, again, not related to the
Actually,
topic,
not
but
related to the issue, and it should be evaluated in the case-to-case basis because
so
there are many local causes also, the bone issues. So, saying the treatment is difficult here, but
right,
whoever posted it, he or she should consult his nephrologist actually for this issue.
right, right, right. Any other questions, viewers who are watching this webinar brought to you by NephroPlus in collaboration with the Kidney Warriors Foundation? Any other questions on access, which is a very, very important topic for all of us dialysis patients? It is important that we understand the importance of and how to care for and protect our access, because our access is literally our lifeline on dialysis. Without a good access, we cannot get good dialysis. So I think there are no more questions. Oh, there are a couple of more questions. भोजन में क्या क्या खाना है यह एक बार बता देते, क्या नहीं खाना है यह भी बता देते, आम का सीजन है, आम खा सकते हैं या नहीं, अगर हाँ तो कितना? I think mangoes is such a
Yeah,
sensitive thing for dialysis patients. So what is your take on mangoes, doctor? आम खा
no,
सकते हैं
it
या नहीं
should
खा
be
सकते?
avoided because there is a definite risk of hyperkalemia.
I'm sorry?
There is a definite risk of hyperkalemia. Potassium ज़्यादा होने का chance बहुत ज़्यादा है. So, and I think we have the dietitian team actually
Right,
to
right.
counsel that
Correct.
regularly.
तो
So,
यस यस यस, प्रीति सागर जी, इस टॉपिक के बारे में हम एक और अलग से सेशन रखेंगे जहां बहुत ही डिटेल में डाइटिशियंस आके आपको आपके हर क्वेश्चन को आंसर करेंगे. देयर इज अ नेक्स्ट क्वेश्चन, सम unrelated questions today's session regarding mental health employment opportunities, as I am a young man diagnosed with RPGN since year ago. I understand your concern, but I think today's session, let's restrict it to access, because what you have talked about, in fact, we just had a session on mental health last month in the same webinar series. But we will keep in mind that there are problems faced by young individuals on dialysis that are very unique. And maybe NephroPlus, along with Kidney Warriors Foundation, can organize a special session on the problems faced by young people faced by dialysis patients. What are the chances of infection associated with AV grafts used for vascular access in hemodialysis? If there are chances of infection, but he or she have no more options of other channels, so what they will do? I think that's one question that may be relevant for a lot of long-term dialysis patients, that if there are no options, what can be done, doctor?
actually, the risk of infection in the AV graft is a bit more than the AV fistulas. So, but if there is the definite infection and AV graft is being the source of infection, we should remove it and do the another axis. If no access is there, then we can choose the peritoneal dialysis.
Got it. Got it.
But
Uh,
the active source of infection should be removed if not managed medically.
right. Right. What is the best exercise for maturation of fistula? I think you already answered that,
Yeah.
doctor, which is the ball exercise. So let's not do that. There is one question here. I don't wear watch or bangles on the fistula arm. Can I do that? Can I wear a watch or bangles on the fistula arm?
If it is not firm, we can use it.
Okay, so I think what doctor is saying, Ruchi ji, is that it should not be tight. It should be just loosely kept. I think bangles should definitely be okay, but watch, make sure it is very loose, not
Very loose.
quite tight, right, doctor?
Yeah,
Yeah, okay, okay.
but preferable to not to use.
Preferable not to use. Yeah, preferable not to use. I have thin veins. Technicians find it difficult to find to cannulate. What are your suggestions to make it easy?
Actually, if the vein quality is not good, we have to do the another access actually. And the isometric cardiac exercise sometimes make the venous better, venous access better. And maintaining the blood pressure a bit higher may help in some cases
Okay, okay.
because there is better chance of arterialization of the venous part in that case.
Got it, got it. I hope that answered your question, Dilip ji. Any more questions from our viewers today on this very, very important topic, our access? Any more questions on access? And we will come up with more such webinars. Like I mentioned, हम हर महीने एक webinar करेंगे जहां हम एक विशेषज्ञ को बुला के एक बहुत ही important topic को लेकर उस पर चर्चा करेंगे. So I encourage you to please follow us on Facebook and Twitter and Instagram and take part, participate, and attend all our webinars in the future as well. And I hope you found this webinar useful. Once again, I'd like to thank Dr. Prasoon Roy. Dr. Roy, closing words, I think, what is one most important message you'd like patients like me who are watching this webinar to take away in terms of caring for their access? What is the one
At first,
piece of
I
advice?
want to thank you for this opportunity to interact with the patients
Not at
because
all.
it's a
Pleasure.
nice interaction. And the take home message should be that you know that your lifeline of dialysis is the your access. So handle it properly, carry it, and visualize your lifeline. So take care of it.
Great, great. Thank you so much, Dr. Roy, for taking the time out today. We really appreciate you, doing this. And like I said, along with Kidney Warriors Foundation, NephroPlus will come up with more such webinars. हम हर महीने एक webinar करेंगे जहां एक बहुत ही important topic dialysis को लेकर जो पेशेंट्स के लिए बहुत ही लाभदायक होगा, जो बहुत ही यूजफुल होगा. So please watch out and attend these webinars. I hope you found today's session very useful and you have something to take away from this session. Thank you once again to Kidney Warriors Foundation and Vasundhara Raghavan for joining this initiative and collaborating with NephroPlus on this very important series of webinars for dialysis patients. Thank you all viewers for joining us today. Thank you. Thank you so much, Dr. Roy.
Thank you.